This is the first reported percutaneous transcarotid transcatheter aortic valve-in-valve implantation performed emergently with percutaneous axillary extracorporeal membrane oxygenation, life support, and transeptal antegrade aortic crossing. The patient is a 65-year-old lady with a medical history of aortic valve disease and multivessel coronary artery disease who is a status post surgical aortic valve replacement with a 21 trifecta bioprosthesis as well as CABG in 2012. She also has a history of peripheral arterial disease, cerebrovascular disease, hypertension, hyperlipidemia, and COPD. She was initially admitted with unstable angina, worsening dyspnea, and elevated troponin levels consistent with non-ST elevation myocardial infarction. Angiography demonstrated an atretic lima graft to the LAD and a high-grade stenosis of the SVG to the RCA. She underwent successful percutaneous revascularization of the native LAD and the SVG to the RCA with deployment of drug-eluting stents. Unfortunately, her clinical condition progressively decompensated with development of cardiogenic shock and respiratory failure. She required endotracheal intubation and multiple pressors. At this point, the structural heart team was consulted for further evaluation. Transesophageal echocardiogram demonstrated a severely calcified bioprosthetic aortic valve with restricted leaflet motion. It also demonstrated aortic insufficiency as well as mitral insufficiency. With Doppler data consistent with severe insufficiency, as well as severe stenosis. The patient was taken to the cardiac catheterization hybrid lab where initial abdominal angiography demonstrated severe peripheral arterial disease with iliofemoral vasculature not amenable for insertion of large bore sheets. Right subclavian angiography demonstrated a patent vessel. Left subclavian angiography demonstrated a patent vessel with significant angulated anatomical course. At this point, the decision was made to proceed with a percutaneous approach for insertion of the axillary ECMO cannula and to use the right femoral vein for the venous ECMO cannula. Left carotid angiography demonstrated that the vessel was widely patent and had an optimal course for potential TAVR. The left carotid was considered to be the preferred axis. However, at this point, the patient was already loaded with ticagrelor, aspirin, and fully anticoagulated with intravenous heparin. The multidisciplinary team, including 2 cardiothoracic surgeons, debated about the safety of performing a carotid cut-down and recommended a percutaneous approach. Ultrasound-guided access to the left carotid artery was obtained using a micropuncture technique, and the site was pre-closed using a standard double perclose technique, followed by insertion of a 14 French sheet. Multiple attempts were then made to cross the prosthetic aortic valve in retrograde fashion using multiple wires and multiple catheters, including an AL1 and AL2 and a JR4 and a straight tip wire plus a glide wire, but were not successful. At this point, the decision was made to perform a transeptal puncture and advance a glide wire in retrograde fashion across the prosthetic aortic valve. That wire was then snared in the descending aorta and was externalized via the left carotid artery. A rail was achieved, and a pictal catheter was then secured in the left ventricular cavity. A Safari pre-curved wire was secured in the left ventricular cavity, and a 23 Medtronic Evolute valve was deployed using a standard technique. Once an optimal position was achieved, the valve was fully deployed. Non-selective angiography showed no evidence of coronary occlusion. Echocardiography demonstrated acceptable post-operative gradients. As well as no significant evidence of further aortic insufficiency and an improvement of the mitral insufficiency. The arterial ECMO cannula was removed on postoperative day 1, and manual pressure was further applied for good hemostasis. Left carotid angiography demonstrated less than 50% stenosis at the access site, with the neurointerventional radiologist recommending no further interventions and ultrasound surveillance. The valve appeared to be in stable position and completely expanded. And postoperative echocardiography demonstrated mild MR and no significant aortic insufficiency, as well as an improvement in the left ventricular systolic function. The patient was successfully extubated on postoperative day 2. There were no significant evidence of neurological deficits, and she was eventually discharged on postoperative day 11. She was then seen in clinic for 30-day evaluation and was found to be recovering very well. This is our Baptist Health Heart team, and we'll thank you for your consideration.